Following on our previous discussion, even with the tremendous progress that we've made, cancer continues to be the second leading cause of death in the United States. According to the American Cancer Society, there will be over 1.9 million new cancer diagnoses this year and over 600,000 deaths. In addition, cancer care costs the U.S. $208 billion each year, and many patients are not able to access the benefits of the cancer innovation, particularly those from historically underserved communities. Our expert panelists are here to address the issues and more. Please welcome Dr. Clifford Hudis, the Chief Executive Officer of American Society for Clinical Oncology. Dr. Karen Knudsen is the CEO of the American Cancer Society for the American Cancer Society Cancer Action Network. I hope I got that correct. And Dr. Stephen Ubel is the President and CEO of PhRMA.
Yeah, that's right.
An association representing America's leading biopharmaceutical research companies. Welcome, everyone.
Yeah, thanks for joining us. Great panel here. Let me start with go down the line. Start with you, Cliff. Kind of the one takeaway you want the audience to take away from this conversation. Usually, we get to that point, but what do you want to emphasize? Because when I tell our reporters, that's got to be the top of the story. That's got to be the lead. What's your lead?
In a run-on sentence?
Yes.
We have made astonishing progress over the last decades against cancer, but not everybody has benefited evenly or equally. And we need to strive to accelerate the progress and spread that wealth.
Okay, that's great.
Yep, breakthroughs since 1991, which was the high watermark for cancer mortality rate in the country. Overall cancer mortality has been reduced by 33% through investment in cancer research. But we need to push forward to ensure that there's access to these breakthroughs, which will require policy and also addressing direct patient support across the U.S.
Steve?
The risk of going last. I agree with everything that's been said. I think we're in cancer moving from what used to be referred to as science fiction to science in action. So CAR T has been mentioned, taking cells out of the human body, reintroducing them on sort of smart bomb missions to kill cancer cells and spare healthy tissues. It's not just early diagnosis and new treatments, but also prevention. Dr. Carnival mentioned this. I think vaccines are underappreciated. You think about, girls who've been vaccinated for HPV have a 90% less chance of developing HPV. And I think there's some really exciting advances on the horizon in the vaccine space. So yeah, super exciting time. We have to ensure we have equitable access. And the policy environment is concerning. And I know we'll touch on that.
And let's jump right in with that one. I remember many years ago being with a lot of health stakeholders, including you, Steve, and the effort had started to pass the Cures Act. And as you remember, it was bipartisan, but I got to the end of the year and it was touch and go. And that legislation, now law, has been received well. The Inflation Reduction Act was not bipartisan. And I want to get kind of your take on kind of those two bills, but in particular, why you have a problem with the IRA.
Yeah, I think that, first of all, let's start with, one of the few good elements of the IRA is there's an out-of-pocket cap of $2,000 for seniors. That's going to be a really impactful policy. Another policy we supported is allowing seniors to be able to spread their costs across the calendar year. So you don't have sticker shock early in the year where you have to meet your deductible. So that means that no senior is going to pay more than $167 a month for their medicine. That's a really important reform. Unfortunately, the price setting provisions of the IRA are really already throwing sand in the gears of the progress that we just talked about a moment ago. And I'll try to explain what I think is the most acute problem we refer to as the pill penalty. There's two types of medicines, small molecules, which are pills, and biologic medicines. The IRA sets forth 2 time frames before the government will set the price of the drug. 9 years for small molecules, 13 years for biologics. So what's the problem? First of all, small molecules have some special attributes. When you're talking about cancer, there are certain proteins that you can only go after with a small molecule. If you think about mental health, small molecules are the only medicines that can penetrate the blood-brain barrier. We're talking about equity. It's a lot easier to access a pill than it is to go get an infusion or go to the doctor, go to the hospital. So the pill penalty, what we refer to though, is that 9-year time period. So the FDA requires you to test your drug in the sickest patient population first. And then only over time, as you gain experience with the medicine, physicians may use it in concert with other therapies or in other adjacent disease areas. You might get positive signals that actually, let's say a breast cancer medicine is working well in colorectal cancer or other types of cancer. The problem is 60% of the time, those positive signals occur in year 7 or later. And those trials, if you decide to pursue a trial for FDA approval, can take several years. So if the government's going to set the price of the drug after 9 years, but you're not going to commence a study until year 7, you have 2 years to recoup your investment, we're already seeing a flight of those research projects being canceled within our R&D pipeline. So this is a really acute problem that's going to really impact the fabric of incremental innovation and getting additional indications in other disease areas. Many cancer medicines have 10, 15 indications that are grown over time that are really going to be jeopardized by the IRA.
Karen, the Cancer Cures Act was a big initiative, as I mentioned, from both parties, but it was a big deal for then Vice President Biden. As president, how is Biden doing in the fight against cancer?
Yeah, well, we're very enthusiastic about some of the progress that has been made since the moonshot has been reignited. Mm-hmm. Just a few examples come to mind. In addition to the investment in cancer science and in cancer research, it's the case that policy changes that affect millions have been pushed by this administration. So up until January of this year, if you tested positive at home for colorectal cancer risk with something like stool-based testing, FIT testing, then now you face a penalty at the level of the next most important step, your colonoscopy. It was no longer completely covered because now it was no longer screening, it was diagnostic. So these are the kinds of policies that actually truly presented barriers to care. People were screening positive at home and then not going to their follow-on colonoscopy. So, an incredible advance that was pushed by the Biden administration was to ensure that this follow-on colonoscopy was now completely covered. And they proposed this to CMS. This happened as of January of this year. As you sit here, that became reality, and that can affect millions. One of the ones that we're very excited about that will come into effect in January of this year is a realization of something we've been really advocating for based on evidence for years, and that's patient navigation. So oncology patients who are navigated understand their care. They're much more likely to complete their care as planned. They overall have a better outcome because of those two attributes. But it's also the case that the health system wins. Those patients, we heard about value-based care in one of the previous panels, those patients largely do not end up in the emergency department and have an overall lower cost of care. From the American Cancer Society perspective, this is what we call all boats rise. So educating elected officials, working with the Biden administration and with other organizations, we were able to successfully advocate for this. And as of January 2024, lay patient navigators will become a reimbursable component of cancer care. And if we look at the evidence and try to identify what is a singular action that could be taken in order to enhance equity in cancer care outcomes, it's patient navigation. So we're very thankful to all the partners who helped us get that done, but especially so to the Biden administration. So I think these are two great examples about using the White House as a way to get access, to get enhanced access to breakthroughs to patients.
Cliff, you've said that simply ensuring patient access to state-of-the-art care would improve outcomes by 20%. That's a lot. Can you explain that?
Yeah, so as we know, there are a wide range of experiences for patients diagnosed with cancer, and Karen just highlighted just one of the examples. In those states that have expanded Medicaid, we've had a real-life example demonstration of what happens. Disparities in terms of time to diagnosis of cancer and time from diagnosis to the treatment of cancer have been narrowed and eliminated, and classical race-based differentials have been eliminated in those states as well, colon cancer being a concrete example and others. So there's a broad set of data that consistently points to about a 20% lack of high-quality outcomes in people who are disadvantaged in accessing the healthcare system. That's where that estimate comes from. If we address that lack of access, we could close that. And I want to emphasize something about this, because this is low-hanging and, forgive me, cheap fruit. We can develop all the exciting new treatments that we want, and we can make bold advances in treating a variety of diseases, but we could almost overnight make the single largest population-based advance in cancer care outcomes if we eliminated these gaps.
You mentioned cheap, and Steve, I want to go to you because obviously when moving legislation or talking about healthcare, cost always comes up. But as Sarah was mentioning the stats, it's stunning how much cancer really, it just causes so much pain, and it also is expensive. But then you have lawmakers, some who say, well, we can't spend that because we don't have the money. So can you talk about prevention and how that factors into policy making and convincing the people who are making the decision, no, this is actually cost effective, but you got to invest?
Yeah, I mean, I think that first on the equity front, I do think it's multifactorial, but it'll get to your question. One of the biggest impediments is out-of-pocket costs for medicine. And research suggests that Black patients abandon their medicine after medicine costs $125 or more. And to me, that points to the need to really make sure that we're looking at the system as a whole to address inefficiencies that cause patients to pay more for their drugs than they should. We've long talked about inefficiencies, whether it's health plans and PBMs or whether it's hospitals in the context of the 340B program. Drug manufacturers are now capturing about 50 cents of the dollar of the list price of a drug. That means the rest of it is being absorbed by other actors in the system. And we know that this arbitrage is really swelling in the system. So whether it's plans and PBMs that are capturing these enormous discounts and not passing them on to patients, or the 340B program where they're getting massive discounts on drugs, 50, 60%. Hospitals turn around and mark up the cost of the drug by 500%, but no requirement to actually pass that on to patients in the form of lower drug costs. So we've been, leading this advocacy around making sure that we're making efficient choices to ensure that patients are paying less at the pharmacy counter for their medicine.
Karen, what do you hear from consumers / patients / caregivers that maybe you don't think politicians hear enough?
Yeah, well, let's talk about cost of drugs. So what we know, because, we're our key stakeholders, our patients and caregivers across the country, is that 42% of individuals in this country diagnosed with cancer deplete their life savings. That's unacceptable. We also know that financial toxicity is a real toxicity. That is correct. So all the data tell us that this, like any other adverse event of going into a particular cancer therapy, is a reality that's associated with poor outcome. So these are things that have to be addressed. But it's not cost alone. Something that, as we go around the country and support patients in 5,000 communities, that we consistently find that people don't understand enough about, it's what we call the basic blocking and tackling of cancer care. So when I was a healthcare executive leading oncology for an 18-hospital system, 16% of our patients could not complete their care as planned because they didn't have a ride. Things like transportation, lodging are key determinants of whether or not someone is actually able to complete care as planned. So ensuring that those basic elements of access to cancer care, understanding that cancer patients are frequent flyers, 5 weeks in the chemotherapy unit, 5 weeks at radiation oncology, it's just not tenable unless someone lives near a center for advanced care for them to get access to participation in a clinical trial or to make a life-saving decision about the kind of care that they will receive. Unfortunately, these social determinants of health, which include transportation and lodging, are key factors that, just like understanding the biology of disease, need to be addressed.
Same question to you, Cliff. What do you think?
Well, this is actually a pet peeve of mine, and it picks up on what Steve highlighted and what Karen talked about. So I want to just paint a scenario to you for a moment.
Okay.
Novel therapies come through the academic and development pipeline. They're evaluated by our membership. Guidelines are written. Quality standards are established. Metrics are generated. Reports are generated. From all of that, FDA approval is garnered. Payers agree that there is a pathway on which that treatment falls, and they agree that that's the optimal treatment for a patient. A doctor prescribes the therapy. They go through a rigorous, onerous, burdensome, and time-consuming pre-authorization process. So the payer has now agreed that the patient is being treated the way everybody says they should be. They go to the pharmacy to get their pill prescription like Steve described.
Right.
And what's the last thing that happens? They're asked for a copay. Why? Everybody's already agreed that they should get the therapy.
Right.
We've added a barrier to compliance, and there is high quality evidence that is consistent in this way. The more the out-of-pocket expense, the lower the compliance. It is that simple. So tell me the rationale in our system for putting all this investment in to make sure that everybody's doing the right thing and having the final step be an overt impediment to compliance, which has zero other benefit or function. The most extreme example is from about now 15 years ago when imatinib came out, an oral therapy that revolutionized chronic leukemia. And so revolutionary that I had friends whose spouse diagnosed with CML was dismissed by them as, oh, it's just CML. You have to appreciate, as a medical oncologist when I trained, there was no just CML. That was a difficult treatment pathway ahead. So with imatinib, oral pill taken, with an out-of-pocket expense, there were academic papers that showed that compliance fell with each $5 increment in the out-of-pocket expense. And from my point of view, we should be paying people to take the drug because it reduces the total cost of care, delays the use of much more expensive therapies, keeps them in the workforce, paying their insurance premiums, contributing to their employer-sponsored healthcare plan. So I'm sorry to go off on this, but this is an example of the most basic, fundamental non-alignment of resources. And I have to say, there is no particular defense for this. It just is.
And I don't want to interrupt, but one of the symptoms of financial toxicity is reducing drug intake.
Right.
So the way that people handle that is actually by having pills and then trying to meter it out, thinking that half is better than none, which may or may not be true, but is often associated with a reduced, a reduced opportunity at a positive outcome. So Dr. Hudis is spot on.
I just think we should charge everybody $10 or more for their insurance and not have out-of-pocket expense.
Mm-hmm.
This is actually very unique to medicine.
Yeah.
If you or I go to the hospital or the doctor, we're paying the negotiated rate between the insurer and those entities. It's
right.
only with regard to drugs that you're showing up at the pharmacy or the hospital or doctor. You're paying oftentimes the full list price of the drug, even though there are all these other efficiencies in the system, whether they're rebates and discounts or discounts in the context of the 340B program. So we have to rationalize the intermediaries in the system so that we can lower costs for patients.
Yeah, and I'm sorry, but I just have to simplify that. We've all agreed what the best treatment is. We've all agreed that this is compliant. We've all agreed it should be paid for. But the last thing we do is make you pay a little more.
Mm-hmm. Steve, your company's association clients of PhRMA are at the forefront of innovation. What are you excited about? Because innovation doesn't really attract a lot of headlines. But then we start to see, really no one was talking about AI 4 or 5 years ago, and now it's going to revolutionize basically every industry, including journalism. What are you excited about in the next 5-10 years?
Yeah, it really is the tale of two cities. It's never been more exciting on the science side for our industry, and it's never been a more toxic political environment. I'll touch on both. You think about what's happening every day. There's a headline, we have curative therapies on the horizon for wretched diseases that not only impact patients from a human suffering perspective, but have enormous downstream healthcare costs and societal costs. Diseases like sickle cell disease, hemophilia. These are patients that are visiting the emergency room frequently and just enormous suffering that are going to have curative cell and gene therapies. We've talked about some of the advances in cancer. But on the flip side of that, just today, the administration is announcing this new framework for march-in rights that's going to allow the government to potentially seize your intellectual property or set the price of your drug if you collaborate with government. Which, the U.S. ecosystem innovation, the reason it leads the world in the development of new treatments and cures is that our companies can collaborate with government, can collaborate with academic research centers. Everyone shares in the fruits of those discoveries if they occur and become commercialized, all for the benefit of patients. It is the envy of the world. I was in Tokyo 2 weeks ago. Mm-hmm. All the Japanese leaders, including the Prime Minister, are enamored with Cambridge, Massachusetts. They want to recreate one of the high-performing clusters in the United States. How do they do that? They're looking at the Bayh-Dole Act. What's our administration doing? They're going to undo the Bayh-Dole Act, which enabled this collaboration to occur. If the price of collaborating with the government is that your patents are going to be seized or the price of the drugs is going to be set, there's going to be a lot less collaboration. That's going to jeopardize our health security, cede our leadership, and it's really going to cost patients future treatments and cures.
Karen, we're going to go back to access issues and gaps and cancer screenings. And you tell us a little about the Color Health Initiative.
Yeah, Color Health is something, it's a unique partnership that we lifted up just a few months ago between the American Cancer Society and Color Health. Now, Color is largely a genetic testing organization that assesses, essentially democratizes someone's ability to understand their own cancer risk. Developing a tailored, bespoke screening plan for any individual is about more than just their age. It's about their age, their family history, their genetic history, and their exposures. So the Color Health ACS partnership is meant to get rid of the friction points that reduce individuals from going into cancer screening. We know that screening and early detection has to be part of ending cancer as we know it for everyone. So what we're doing is working with this program with mid and large size employers to bring on this partnership at the level of their HR benefits so that people have an opportunity to understand how and work with us with our guidelines and Color's genetic testing to develop the right screening program for them and then navigate them. So within your existing already paid for health plan, your colonoscopy is covered. Let us help you get the appointment to that person. It meets all of our goals toward getting more individuals into prevention and early detection.
Mm-hmm. Cliff, just want to talk about the disparity between healthcare across the country. Do you think that how much of a problem is access to care and quality care in rural areas of America?
It's a huge issue and it's getting wider. As we make these advances against cancer, we see falling mortality rates. They are not falling as steeply or as quickly in rural areas, which suffer both the burden of, in many cases, lower socioeconomic status and the added geographic burden in terms of access to care. The remedies, I think, are on the horizon there. Obviously, the broadened access to care through the telehealth liberalization that came out of COVID has been very helpful. Reducing the administrative overhead related both to care and clinical trials has enabled patients in those areas to participate in cutting-edge treatment and research more easily. We have a project at ASCO in Montana that uses a hub and spoke model with a center of excellence in a larger city, and then nurse practitioners, physician assistants, and internists and others in a rural site hundreds of miles away, guided by the center to deliver prescribed care and monitor the patients. And we think that's going to be a scalable way to begin to address this challenge. By the way, I think it also will probably work internationally to deal with disparities as well. So it's universal.
Let me go a quick lightning round as we finish up. Steve, we'll start with you. Just something positive, and with mixed in, are these goals from the Biden administration, Congress on cancer achievable?
I think they are achievable. There's a lot of tailwinds behind us on the science side, but I worry that we're sort of sabotaging the rocket that's trying to achieve the the effort. So I think we need to nurture the ecosystem that has produced a lot of the innovation that's occurring and not throw sand in the gears.
Karen?
Yeah, I would say exactly that. Let's keep up the momentum, and let's also leverage some of the big wins we've had in actually having a cancer vaccine that has now given us the first, as of this year, real world evidence that we can end cervical cancer as we know it and other HPV associated vaccines. We've just got to take action as a country and get people vaccinated. And to build on the opportunities that we learned about with COVID and mRNA vaccine technology and leveraging that toward new cancer interventions.
Cliff, last word.
Sure. So I think that the 30 or 40 years now of progress is not going to be slowed. I think the scientific advances are remarkable. And I think I'm optimistic because despite all of the political infighting, we've actually reached a point where the highest proportion of Americans ever are insured and have access to care. And I think we have to figure out a way, an affordable way to continue those trends. Every study we do that looks at addressing these disparities and closing these gaps shows deliverable improvements in health.
So there's a lot of hope out there.
Absolutely.
Well, please thank our expert panel for joining us this morning.